From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Hello and welcome to our listeners around the world. You're listening to the JAMA Psychiatry Author Interview podcast. I'm your host and web editor, Dr. John Torous. Today we're thrilled to be discussing a new paper just out in JAMA Psychiatry, providing timely access to diverse youth mental health services, results from the Access Open Minds study. We're about to be joined by the first and corresponding author of the paper, Dr. Srividya and Iyer, PhD, at Douglas Mental Health University Institute at McGill University in Montreal, Canada. We all know that most mental health disorders begin during youth and that timely access to care is critical for the most effective treatment and moving us as a field towards prevention. But realizing timely access to youth mental health services has remained challenging and new approaches and innovations are needed. To learn more, we're going to explore the results of a brand new study just out in JAMA Psychiatry. So thank you so much for joining us, Dr. Iyer. And to jump in, you start off the paper by noting that 68% of mental health problems emerge before age 25. If we know that this is when the mental health conditions are emerging, this is when we need to act, why has it been so hard to make progress? We know what to do, or when to do it at least.
It's an excellent question, Dr. Torous, and I would probably argue that it's the major challenge for our current times. So indeed, the age of onset, we've known for a while that it happens in adolescence and young adulthood. We also know that, in fact, youth mental health problems are on an increasing trend nearly in many parts of the world. And yet, as you said, meaningful progress has been difficult. I think there are many reasons for this. One, I would say that this is no different from mental health as a whole. There's been stigma-based neglect of mental health worldwide, and this is one more example of that. And then in general, society has not always paid attention to the needs of young people. So this is a combination of the two. In psychiatry and mental health, our systems have not really been set up to focus on this period of late adolescence, early adulthood. We had the child adolescent and the adult systems. Young people also interact with various sectors in society, like school, hospitals, healthcare, social services, and these are all so siloed and fragmented that often young people and families get sort of lost and fall between the cracks of these systems. We've never asked young people what works, so we keep designing things that we think work, but they don't really work for young people because they're not youth-friendly. And then I would say one important thing that I would also definitely raise is the question of the complexity in part of the nature of both adolescence and young adulthood, both the beauty and complexity that it's a time of change, it's a time of transitions. And the nature of mental health presentations at this stage is also sometimes hard to tease apart from some of those tumultuous nature of adolescence, the overlapping nature of what should you pay attention to, what extent things are overlapping, what should be treated in a formal system. These are all questions that still seem to plague the field a bit. And I think when you put all of these factors together, it really is the reason for the neglect. I mean, I would say that with this paper and other work across the world, there is really an increasing, optimistically speaking, there is increasing attention to this issue. There's a lot of hope for early intervention. You have EpiNet in the US. You have many such models like Access and others in Canada. And I feel like it's actually really, the signals are very much in the positive trend in terms of at least wanting to pay attention to this and do things differently and focus on prevention and early intervention.
And on prior podcasts, we focused on the EpiNet, which is for early course schizophrenia. But what I really want to ask you about is, what is the Access Open Minds project and what does it focus on and who does it serve? Because we haven't covered that before, and that is the topic of your paper.
Perfect. Access Open Minds was a research network funded by the Canadian Institutes of Health Research and the Graham Beck Foundation, and it very much shares principles and inspiration from early intervention for psychosis, but also models for integrated primary or community-based youth mental health service delivery models. And the essential nature of this project was to develop implement and evaluate a new approach to serving young people between the ages of 11 and 25 across 16 very diverse sites in Canada that included urban contexts, rural, remote, Indigenous, both First Nations and Inuit, post-secondary and homeless youths across Canada. So the idea was really if we can try and represent within our settings as much of the diversity as exists, both in terms of geography and culture, but also in terms of service context and structures. And the model itself was based, because we were working in such diverse settings, we really couldn't implement a very manualized model across context. So what we did was we identified 5 key principles that we then implemented according to local preferences, local resources, and local cultures. And the 5 principles were early identification, so targeted outreach to increase referrals and the number of young people seeking help and seeking help early on in the course of their mental health problems. The second was to ensure that access to mental health services was timely and it was in an engaging manner, so that not only was it timely, which could happen in an emergency room, but that this was happening in primary or community youth-friendly walk-in spaces where people felt welcomed. So this was sort of a second component, rapid engaging access. The third was to ensure that the care that we provided was appropriate, both developmentally but culturally as well, and really attuned to young people's needs and preferences and the stage of the problem that they were presenting with. The fourth principle was continuity of care, really ensuring that services were provided for as long as young people needed and that we didn't have age-based transitions, so that there was really this principle of following people for the time that they needed rather than abruptly stopping services at age 18. And the last is more like a value that really was infused throughout our project, which was about engaging young people and families in designing services, in their care, so really making sure that lived experience, both young people's and families, was fundamental to the design of the services. So this was a research project. So we were really interested in continuously evaluating these principles to understand their implementation and impact. So it was a services research project. And the network itself, it's a large network that has young people, families, service providers, researchers, Indigenous community leaders, policymakers across the country.
It's really quite remarkable to be serving such a, as you said, diverse population across so many different metrics, but to have those 5 principles really infusing, you could argue, the best of evidence-based care, of values, compassion, lived experience. That's a wonderful model. And as you said, in kind of doing this in a clinical translational research model, you and the team were evaluating stuff. So what type of benchmarks and goals were you using for this Access Open Minds clinical research network, I'll call it?
Absolutely. So broadly speaking, we were making sure to assess progress across those 5 principles, but we did have some benchmarks for core things that we wanted to make sure happened across all sites. One of them was we wanted to make sure that if young people sought help, or if others referred young people, that we responded to them with an offer of an initial appointment within 72 hours. So if they walked in, it's easier, but even if they didn't walk in, that we would offer this within 72 hours.
That's fast.
And and that is fast. And if you know the Canadian system, and this wait times are an issue across the world.
But even the US system, 72 hours is unheard of.
Absolutely. And the reason we picked 72 hours, it was a benchmark that's long used by Canadian Early Psychosis Services, and it was deemed acceptable in this study as well by young people and families. Part of what we did was this initial evaluation was with a trained non-physician professional. And that, I think, was the key to removing the bottleneck of focusing really on specialist care, because it might create difficulties in following this sort of a benchmark. And then we also made sure that referrals could come from anywhere. So we don't have a gatekeeper model with a general practitioner being the first portal of entry, which often happens in universal public healthcare systems. So young people could just walk in, families could refer, peers could refer, schools could refer, elders could refer. So it was really a model that we allowed the 72 hours as the benchmark. The second benchmark, which we followed, was that services and interventions needed to be started within 30 days of the first appointment. And this is the benchmark that the Canadian Psychiatric Association recommends for non-urgent cases. And by no means did we want people to wait for 30 days, but we wanted to make sure that it was no more than 30 days, and where possible that we were actually offering services as quickly as possible. And this is a vast improvement over the usual wait times in Canada. So these were the two kind of core benchmarks that we did evaluate in two of our three hypotheses, as we can talk about a bit later, hopefully.
And now that we understand what is Access Open Minds, the principles behind it, some of the core evaluation metrics, to do this study, you had numerous sites, as you explained. And which sites are you going to include in this analysis? And what is kind of the expected cohort or what you were planning for?
So in the entire network, we had 14 sites across the country that participated in the network. So like I said, urban, rural, remote, 6 of the sites were in Indigenous communities, post-secondary and homeless. In the study itself, we had 12 out of the 14 sites that participated. So the 2 Inuit sites up north really didn't think that the evaluation protocol aligned with their community preferences. So while they transformed their services, they did not really participate in the evaluation protocol. We did something quite different for evaluating the impact of the service transformation in that context that was a lot more community engaged and community led. We did set some site targets for each site based on the number of young people who live in each catchment area based on the census, the number of young people we know from prior community epidemiological studies that typically seek help, the unmet needs estimates that we had for each site. So we had a target that we had in mind for each site, and we actually achieved way more than that target. So we realized very quickly that we surpassed that target in each site individually and as a network as well, which speaks a little bit to the fact that there are, I think, probably huge needs. But if you did design primary community-facing, youth co-designed services, people will come to these services.
It sounds like the demand is huge, and I think we can all agree it's going to be a global phenomena for this demand. It's nice that you're doing Canada, but the same issues are everywhere. And in doing this research, you have 3 hypotheses that you lay out very nicely in the paper. Let's briefly review each of them, because we're going to talk about the results soon. But what are these 3 core hypotheses that you have?
So we were interested in understanding whether this type of service transformation impacted the reach and timeliness of services offered to youth. So as such, our main hypotheses were that over the course of the Access Open Minds implementation, we would be able to see an increase in the number of young people seeking help or being referred, our first hypothesis, an increase in the number of young people being offered an initial mental health evaluation within 72 hours of referral. And our third hypothesis was that we would see an increase in the number of young people receiving services within 30 days of their initial appointment. And maybe one nuance to mention is that we were really keen on making sure that we evaluated these results separately for young people with and without moderate to severe mental health problems, because there have been some concerns in the past about the responsiveness of primary and community-based services to youth with more serious problems. So those were our 3 primary hypotheses, and we had 3 additional secondary hypotheses as well that we can come to at another point during the podcast, if time permits.
So you have all these sites you explained to us about, and data was collected from March 2016 to December 2020. Mm-hmm. What was the total sample? And maybe give us just a quick flavor about the different demographics or clinical background of who made it into this final sample from all these sites across Canada.
So from March 2016 to December 2020, in the 11 sites that are part of this cohort study that is reflected in this JAMA publication, 7,889 young people were referred to the sites. Of them, 4,519 received an initial evaluation before March 1st, 2020, and for whom we had consent and they participated in this study. What's really, really exciting and noteworthy is that this sample included very diverse young people, like about 23% who were indigenous, about 22% who were visible minority, about 7% gender diverse, about 39% sexually diverse, about 34% of young people who are not in school or not working, what are typically called NEET young people, and about 40% of young people who had difficulties meeting basic needs. So really, we did something right, or we think we did something right in terms of making sure that young people who are typically underserved or typically reluctant or known to be reluctant to access services were seeking services in much higher numbers. In fact, their proportions were much more than their proportions typically in the general population.
And your paper has so many fascinating results. I encourage everyone to read it. We'll quickly cover maybe the three main hypotheses. Around hypothesis number one, which was increasing the reach and the number of help seekers, what was the high-level result there?
So as hypothesized, we had a 10% increase in the rate of monthly referrals for every 6-month period. And that's the first finding. Second is that this did not plateau. So for some sites, we observed them all the way to 29 months, for some for 48 months. But this did not plateau, which means we need to maybe have longer periods to know if at some point this would plateau and we would have served most of the people in a community and then have only new cases at a steady rate. We didn't see that happening in the period that we saw. So the third, perhaps key point to make is that the growth is not the same across sites, which means that maybe different sites based on some sites had younger people more at risk for mental health problems. Some sites might have been different with their outreach activities. So we were not able to tease a lot of that in this first paper, but there is high levels of site level heterogeneity, which is not unexpected. But overall, there is an increase, and some part of it reflects an increase because of our outreach, perhaps. But the other is what you had mentioned earlier, that clearly there are increasing trends of young people seeking help. So some of what we caught might also be attributed not just to our outreach, but to the fact that more and more young people are indeed seeking help for mental health concerns.
It's still a very impressive result to find that many new people. And for the second hypothesis, which was around a 72-hour goal, which is, again, very impressive to get back to folks, what was the main result around that second hypothesis?
So maybe two ways that we looked at it. First, we were just interested in the probability of being offered an appointment within 72 hours and whether that improved over time. And we did find that with every program year, more and more young people were seen within 72 hours. So we start at about 48 and then we go on to 64. But then we did more sophisticated analysis to account for the fact that we wanted to account for clustering by site, but also all possible characteristics of young people that might influence wait times. And we still found that there's about a 3% decrease. So over time, the delay between being referred or seeking help and getting this first appointment decreases by 3%. What is concerning and maybe a bit surprising is that we found that those with moderate to severe mental health problems had 14% longer wait times compared to those with no to mild mental health problems. And the reason this is concerning, I'm glad we did this analysis. A majority of them got care quickly. And that's important to note that we're still talking about very rapid responses, but there is a difference between these groups. And it is concerning because most of the research that we have about the harmful or deleterious effects of treatment delays are actually for people with more moderate to severe mental health problems. So we really do need to really think about how to enhance the capacity of these primary or community services to respond more quickly to young people with more moderate to severe mental health problems. And some of it could also be young people level factors like, stigma or lack of social support, or maybe like hesitation after first seeking out help in actually pursuing the first appointment that was given. So there could be a lot of factors, but nonetheless, this is something that is a clear direction that we need to take in the future to reduce this inequity.
And for hypothesis number 3 around connecting people to help and services within 30 days, what was the result there?
What we found was that even in the first year, 85% of young people got services within 30 days. So already we met that benchmark and it increased over time. But what we did also notice is that many more people, about 79% of people by year 3, so an increasing number of people started getting services on the very first day, which I think is a nice improvement to see. You know, 30 days was not our aspiration. It was our maximum time. So we were very happy to see that change and that there was this decrease in delays. But once again, we did see the same pattern where young people with more moderate to severe mental health problems had slightly longer delays to getting appropriate services. And in this case, we think it is harder for primary or community services sometimes to link young people to specialists or to specialist services like First Episode, whether it's for bipolar or psychosis, it's not always accessible. And there might be delays. Nonetheless, this is something, as I mentioned, that we do need to try and rectify in the future.
I think anyone listening would agree that, again, if you have a way that you can respond to people within 72 hours, connect them to care within 30 days.
It is exciting.
Increase the number of help seeking. This is a tremendous win. And
absolutely.
For those of us listening around the world who aren't, say, in Canada, how can we take some of these lessons and apply them into our practices, our healthcare systems, and try to do what you guys are doing?
I agree. It is exciting, and we do have a lot that can easily be implemented now to transform systems of care. I think the first thing that this shows is that we can change the cultures of mental health care for young people, and that we can do so in very diverse contexts for very diverse young people. So I think that that's exciting. Second is that the key idea over here is that it's not a fixed model, that you have some core objectives or principles that have been identified based on both evidence, but also lived experience involvement, and that these then need to be implemented in a context-sensitive way. So the idea of core principles implemented in a context-sensitive fashion would probably be at the heart of transforming services. Then maybe a last thing that I would say is that in general, like what we found, if it's not a result, but something that I think very much is at the heart of the project, is that you really need to be guided by both head and heart. So you have the perspective of, the rights and voices and values and extreme high levels of cultural sensitivity. But we were also very much sensitive to making sure that we were collecting evidence and evaluating everything we were doing. So that combination of paying attention to evidence and ongoing learning and improvement, but coupled with values, rights, and voices is really at the heart of what we need to see happen more and more if we are to transform mental health services and provide early intervention that's hope-inspiring for many young people.
Yeah, I really do think this is the future. You said it's core principles, but it's flexible, it's culturally sensitive and adapted. And you said it's evidence plus values. It's not just sending everyone a manual and saying, if you don't follow this manual, Dr. Iyer's going to call you. It's a much more realistic way to run it. So maybe one last question. There's always more to do in our field. So what would you want to say are maybe the priorities to focus on or research gaps to expand Access Open Minds or hopefully programs like it that you inspire?
Thank you. I think we're at an interesting juncture. The first is the question of scale. How do we then scale innovations that we know work across more contexts, more settings, both within Canada, but also globally? The second is I think we have a lot more of an understanding of what needs to be done to increase the numbers of young people who are seeking help, or who can be matched quickly with help. But now we need a little bit more knowledge about what happens. Are we matching people with the right level of services? How long should people be followed? There are some complex questions around that we need to address fairly quickly. So we've done an initial part. The second part needs to follow. We also, I think, really need as a field to have a better understanding of larger trends in society that are impacting young people, whether it's social media or climate change, and how best to integrate those understandings both at individual level care but also in system level solutions that we are proposing. I think that more and more, if you talk to young people, they will tell you this, that this is important to find a way so that to what extent do we think about individual service clinical solutions and how do we integrate social, political, economic responses within that? And then maybe one last thing that I would say is we really need to reimagine a little bit some of our interventions and our workforce. We can't really focus on one-on-one specialist level. We don't have that many specialists, and it's clearly not also working for everyone. So I know you do a lot of digital work, but we really need to reimagine a little bit the landscape of what is possible in terms of workforce interventions and what outcomes matter to young people. But I do think we're poised. I really would like to make that note of optimism. I think we're really, really well poised to build on work that has been happening over the last 2 decades in early intervention to be able to ask these questions and improve systems and scale them to have better impacts for young people.
It's inspiring to hear this vision for the future, but even more so to see this amazing work that you and your team did, that it's too little to call a foundation. It's an inspiring tool, system, research project. It's more than that, right? That we can all use it and benefit from them.
Thank you so much. I agree. And thank you for this opportunity to talk about the project and talk about a project that I've spent a good part of the last several years on, but one from which I feel like I've learned on an everyday basis about how to both retain the optimism of early intervention, but to really think about the hard work of implementing it in diverse settings.
I'm John Torous, and I've been speaking with Dr. Srividya Iyer about providing timely access to diverse youth health services, results from the Access Open Minds. To learn more about this research, you can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.